One of the things that seems to be coming up in this conversation is that we've got lots of different treatment options. And it's a little bit challenging right now, given the current data, how we select patients for each one. And actually what I'd like to do is sort of go around and just get people's sense of how do you think about sequencing these various different treatments. We could start with carcinoid patients, for example. Might be a little bit easier than pancreatic, but Diane, when you see a carcinoid patient coming into your clinic, how do you think about the sequence with somatostatin analogs, with mTOR inhibitors, with PRT coming down the line? How would you select a treatment?
So generally speaking, for a carcinoid patient, I'm looking at about 4 or 5 things as soon as they walk into the door. First and foremost, I want to know what the patient looks like. So is this a patient that clearly looks more chronically ill appearing, unfortunately, that has had disease that is starting to, pick up its pace, and you could see that just on the patient. Most times, thankfully, for carcinoids, the answer is no, that they're pretty asymptomatic, and we're going to go with this is an asymptomatic patient in terms of looking well. The second thing I ask is, do they have hormone-related symptoms? Is this a functional or non-functional? If it's a functional tumor, I don't have a lot of time to wait. I want to treat that sooner rather than later. The third thing I look at is what they look like inside. What does their cross-sectional imaging look like? So we've talked a lot about, the different scans that we do. PET scan, the traditional PET, is not good for this disease, for a well-differentiated neuroendocrine tumor, that is, maybe perhaps different in the poorly differentiated neuroendocrine carcinomas. I do a baseline Octria scan because I do want to see that. I tell patients I want them to light up like a Christmas tree, because that is a prognostic good factor. And so they come back and they say, do I light up like a Christmas tree? And then we do woohoo when they do.
That's the one situation where a floridly positive.
Exactly, you're like, yes, you are lighting up. So that's always a good thing when it's somatostatin scintigraphy positive. And then, you look at the burden of disease. So is this someone that has a lot of disease in their liver that I'm not going to wait and say, well, I'm going to see the test of time? I mean, you see in the disease all over in their liver that clearly the disease grew at some point. And then you put all those together and you decide. In a patient who's generally asymptomatic, low volume disease, I will watch them, and I'll tell them in 3 months, I want you to come back. If you have any symptoms, which is unlikely, but I want them to call me beforehand. But in a non-functional asymptomatic patient, if in 3 months their disease is still low volume, hasn't grown, I've really afforded them one cost-effective therapy because all of these treatments are so expensive now, and every treatment has some side effects. And perhaps, I have patients that 2-3 years later, we're still not doing much because the disease just isn't growing. And typically those are older patients. Again, the biology of the disease trumps all here. If they start to grow, somatostatin analogs is what I call my first string players. That's usually what I do. And then if they grow again and it's liver only, I usually do some sort of regional approach. I speak to my surgeons, I speak to my interventional radiologists. Now with the RADIANT-4 data, we have other therapies to consider, and so everolimus is absolutely a very appropriate treatment, which I may use more frequently now. But again, in a patient that's more symptomatic, that's hormone functioning, somatostatin analogs right away to help decrease that tumor burden in terms of the hormone synthesis, prevent carcinoid, the rare but serious risks of other carcinoid syndrome-related problems, and or even consider regional approaches at that time. I actually have clinic with a surgeon because I want to know their opinion and saying, what do you think? Resectable, unresectable, helpful to, and often we'll have what I call a regional approach of both surgery and then embolization later on. So the burden of disease and what the patient looks like becomes really important.
I'm going to turn to James on some of the same questions here, because an interesting question comes up. You've got somatostatin analogs that improve PFS. We now know that everolimus also improves PFS. Do you ever watch these patients?
I actually do sometimes. I think some of these patients who have very low volume disease in very indolent course, you can really potentially watch. I remember a patient that it literally took me an hour to convince the patient that he doesn't need any treatment when I met him probably 12 years ago. And he still has a positive arterial scan. He still has radiologic disease. Now it's 12 years down the road without any treatment whatsoever and still has stable disease. Unfortunately, that's not the case for most of our patients. But I agree with a lot of the points Diane made. I think in some ways is we're developing evidence base, so I'm being a little bit stickler to the evidence base. I think in patients with the I would say bowel neuroendocrine tumor or gastroenteropancreatic net. You have data now from Clarinet and ProMed to really consider SSA, seeing them. In lung neuroendocrine tumor, we still lack that data. I think, how well that works, we really need to answer in a prospective clinical trial. Everolimus now, you have it for lung and the GI and neuroendocrine tumor. So I think it has a pretty broad area that you can use. And when do we use each? I think, like we discussed earlier, it's based on what the clinical situation is.
Right. Jennifer, for a carcinoid patient, in what situation would you think about chemotherapy?
So to date, there isn't a whole lot of data to suggest that chemotherapy really is effective for patients with carcinoid. I think, as Diane had mentioned earlier, sometimes when there's a mixed component of maybe an adenocarcinoma in combination with the neuroendocrine component, then especially when we're sort of reaching for treatment options, that may be something to consider. But by and large, there's not a whole lot of data to support the use of any chemotherapy in carcinoid patients.
With the exception perhaps of the more aggressive phenotypes.
Sure.
So if you're looking at the Ki-67, which is something that we talked about, at what level or what cutoff would you start thinking about using chemo in a carcinoid patient?
Well, so the cutoff for a poorly differentiated or a high-grade tumor is, again, 20%, a Ki-67 of above 20%. So particularly in that population where they're, even if they're a well-differentiated tumor, but their Ki-67 is higher, then chemotherapy may be appropriate in that instance.
And do you have a favorite regimen?
Probably, if there's an adenocarcinoma component, I would probably favor a fluoropyrimidine oxaliplatin like Folfox. Aside from that, temozolomide or I guess not capecitabine so much, but temozolomide-based regimens just haven't really shown that to be of benefit, and especially if it's not of pancreatic origin.
So you'd be thinking along the lines of a fluoropyrimidine maybe in that setting. Sure.
Yeah.
I think I would add, I completely agree, Jen. The one exception is kind of going back to the foregut, midgut, hindgut. Again, small study, so I don't want to be, making conclusions from that. But in patients that have more aggressive disease, for example, in the lung, in addition to platinum-based therapies, temozolomide may be helpful.
Sure.
And it's a little bit tricky when you're dealing with the lung nets because many times those patients have been treated like small cell lung cancers, but in fact we know that they really are more indolent and they don't act like small cell lung cancers, and so they're inappropriately getting chemo when they shouldn't, but then often they also don't have the same classification in terms of pathology, so you may not know the Ki-67 there and you're like, oh, what do I do now for this atypical lung net? But in fact, we have used some temozolomide-based therapies there with good success.
Yeah.
So, and some of the gastric and duodenal as well. So I think we kind of lump those foregut, pancreatic, stomach, duodenal, lung into perhaps when the burden of disease is higher or they're really progressing, some sort of cytotoxic therapy should be considered.